Good morning, everybody. On behalf of my colleagues from the Northwestern Comprehensive Multiple Sclerosis Program, I'd like to welcome you all to our second annual patient symposium and to recognize that this is presented in sponsorship by Northwestern Medicine, the Shirley Ryan Ability Lab, and our colleagues at the National Multiple Sclerosis Society. This is our program for this morning. We're going to start with a presentation on wellness in MS by Dr. James Sliwa, followed by Dr. Edith Graham talking about pregnancy, breastfeeding, and fertility with MS, and then Dr. Gina Perez-Giraldo talking about ethnic considerations in MS. We'll then have a presentation by Suzanne Karen from the National Multiple Sclerosis Society, followed by a 10-minute intermission. After that, we'll return with a discussion of multiple sclerosis and the COVID pandemic, implications for those who are immune suppressed by Dr. Elena Grebensiakova, an overview of hematopoietic stem cell transplantation for MS by Dr. Roman Balabanov, and a talk on progressive MS, a current perspective by myself. At the end of my talk, we'll switch to a question and answer session in which all of us will be available to answer questions that you submit by clicking the icon, where the question and answer icon at the bottom of your Zoom screen. So again, thank you all for joining us, and let's move to our first presentation by Dr. Sliwa.
Okay. Well, thank you, Dr. Cohen. Wanted to briefly talk this morning about wellness and multiple sclerosis, but I was hoping to give you a different perspective. I'm sure you've heard talks on wellness before, and it's not a new topic to you. But as I said, I wanted to frame this a little bit differently for you and give you a different perspective on what could be considered wellness in MS. Before we do that, I just wanted to kind of set the stage here in that, in my mind, wellness is a heightened sense of well-being. So it's a sense of well-being regardless of what your disease or physical condition is. And it is a choice that we make to shape a healthy lifestyle and to increase our sense of well-being. So in my mind, specific to multiple sclerosis, wellness can be achieved three ways: controlling the disease, optimizing your function, and maintaining a healthy lifestyle, maintaining your general health. I contend now that the potential to really maximize your wellness has never really been greater. And this is where I would like to change your perspective a little bit by sharing some history with you in each of these areas. So, multiple sclerosis probably occurred as early as the 14th century, but the first definitive case was thought to have affected Sir Augustus d'Este, the illegitimate grandson of George III. And this is actually what he wrote in his diary in October of 1827. At Florence, I began to suffer from a confusion of sight. Each eye had its separate vision. The melody in my eyes abated. I again saw all objects naturally in their single state. Now a new disease began to show itself. Every day I found gradually, by slow degrees, my strength leaving me. At length, about the 4th of December, my strength of legs had quite left me, and twice in one day I fell down upon the floor. I remained in this extreme state of weakness for about 21 days, during which period I fell down about 5 times, never from fainting, but from my legs not being strong enough to carry my body. This is probably the first recorded description of a relapse, an exacerbation in MS. And this occurred 195 years ago. Well, what was interesting is while it was described and people knew about this, physicians really didn't realize that this was a separate entity. And the delay in describing MS was because physicians had a difficult time distinguishing it from other very common neurologic conditions back then in the 19th century. And there were two very common neurologic conditions that they dealt with, and that was Parkinson's disease and actually syphilis, neurosyphilis. Well, in 1868, a physician by the name of Charcot provided the first detailed descriptions of the clinical manifestations of MS. That is, he said that the tremor in MS was different than Parkinson's disease, and the course was variable and different than Parkinson's disease and syphilis. And he identified MS as a specific disease entity separate from all other neurologic conditions at that time. And that was 41 years later after the first reported case. Well, now that the medical field knew that it was a specific condition, they began to study it. And in 1884, this physician noted the appearance of MS occurring after infectious diseases. And you can see here at the very end of his quote, this is what he wrote in the medical record. I made an effort to renew the idea that multiple sclerosis often starts as an infectious process. So first now, people have identified it as a separate entity and are beginning to study this. And as you can see, these were the treatments back then to help control the disease. Proposed treatments at this time were nervine tonics, such as arsenic, nitrate of silver, and quinine. Also, avoiding pregnancy, cold, stress, fatigue, both physical and mental, and wine. Well, they continued to kind of understand this disease. And in 1896, a physician by the name of Eichhorst reported cases of familiar diseases. And again, he wrote in the medical record, we found nothing else than a clinically and anatomically pronounced case of multiple sclerosis, which was transmitted by heredity from mother to son. So what you can see as time goes on is an understanding of this disease very slowly over time. Well, in 1908, a physician by the name of Oppenheim advanced treatment to control the disease then. And this is the proposed treatment for multiple sclerosis in the early 1900s. Silver nitrates, potassium iodine, a mild galvanic current applied to the back or the head appears to be sometimes helpful. Also, a course of spa baths and leeches are also recommended. It wasn't until 1950 that a physician by the name of Cabot discovered increased gamma globulin in the spinal fluid of MS patients. And this whole immune inflammatory nature of MS lesions became more understood. And in the 1960s, studies proved the benefits of steroids and corticotropin in treating the symptoms of MS, but not necessarily affecting the disease itself. It wasn't until July of 1993 when a new era arose when the FDA approved interferon beta 1b. Since then, multiple new disease-modifying drugs have been developed over the last 10 years. So, described 195 years ago, right? Identified as a separate disease entity 154 years ago. And in the last 10 years, significant changes have been made in the development of treatment to help modify and control the disease. So let's talk about optimizing function. And when we talk about optimizing function, we're really talking about rehabilitation. Well, let me also share with you a little bit of the history about rehabilitation. You know, obviously it's a multidisciplinary approach to increasing physical function. Well, it was established as a medical specialty in 1947, but it was established as a medical specialty after it was demonstrated that members of the military could return to active duty quicker if they didn't recuperate in bed, but rather they got out of bed and they were active and they exercised. Well, this move to provide the same type of treatment to non-military personnel, but to individuals who had an illness, sickness, a disease, really started to gather momentum in the 1950s. Even then, most of rehabilitation was really focused on what I consider or I call a static disability. That is, individuals that have had a spinal cord injury, individuals that have had strokes, broken bones. It wasn't really until the 1990s that the specialty of rehabilitation actually began to address improving function in disease states that are progressive in nature, such as multiple sclerosis. And that's why you see that in the late 1990s, there are studies that are now being published that show that rehabilitation actually improves function in individuals with multiple sclerosis. They made significant improvements in function and self-care and mobility. They improved self-care, transfers, locomotion, ambulation. And the improvements weren't from neurologic change to the MS. It was due to the rehabilitation. But that didn't occur until the late 1990s, almost 2000. And what you see now in the field is even more advancements. And here's an example of what is taking place now to improve function even more. And we gave this example last year of transcranial magnetic stimulation, where actually stimulating the brain, specific parts of the brain, result in active movement and improved function. And when they couple this with therapy, with rehabilitation, what they show is that individuals with therapy make improvement, but individuals that undergo therapy, followed by the transcranial magnetic stimulation, improve function even more. So it wasn't until the last 20 years or so that we really began to understand the benefits of rehabilitation in individuals with a progressive illness. And now we're demonstrating ways to improve function even more. And finally, I just wanted to talk briefly about physical activity and general health. But let me just describe it. Physical activity is really any body movement, produced by skeletal muscles that results in energy expenditure. Physical fitness is really kind of the state of attributes that a person receives. So if you move enough, your physical fitness improves. Well, it is now known that activity is exercise and exercise is medicine. Regular activity reduces the risk of numerous chronic medical conditions and improves overall health. And these are the examples of what it improves. Things like heart disease and stroke and blood pressure and diabetes and osteoporosis and certainly obesity. It's actually been shown to decrease the risk of colon cancer, breast cancer, and it certainly helps cognitive improvement, depression, and anxiety. So it is known now that activity is medicine. It can reduce the risk of numerous chronic conditions. But in the last 10 years, there's also been evidence that activity and exercise does more than just reduce the risk or improve those general conditions. It also, studies suggest that exercise enhances neurologic processes that promote brain health in aging and disease. And this study in 2012 said a current frontier in neurodegenerative disorders, such as multiple sclerosis, concerns the role of physical activity for promoting brain health through protective, regenerative, and adaptive neural processes. So exercise not only reduces the risk of other medical conditions, there's evidence to support in the last 10 years that it also promotes a healthy brain and may actually impact the disease course of MS. And those recommendations are 150 minutes of moderate or intense aerobic activity per week, or 75 minutes of vigorous, intense aerobic activity per week, plus 2 more days of strength training per week. However, they also concluded that any amount of exercise is better than being sedentary. And there are now exercise and lifestyle physical activity recommendations for people with MS throughout the disease course. So in summary, I would just say that in the long history of multiple sclerosis, the potential level of achievable wellness has never been better, and that advances in the last 10 to 20 years have made this possible. And remember that wellness is a choice that we make to assume the responsibility for the quality of our lives. So thank you for your attention.
Dr. Cohen, I think you're muted.
Sorry. Thank you, Jim. We're next going to move to our next talk by Dr. Edith Graham on pregnancy, breastfeeding, and fertility in multiple sclerosis. Dr. Graham.
Thank you, Dr. Cohen. I'm going to share my slides now. Okay, thanks, Dr. Sliwa, for that historical perspective on multiple sclerosis. You can see how many advancements we've made over the years and the importance of rehab and wellness in multiple sclerosis is forefront in our minds here at Northwestern. And one of the things that I'm going to talk about today is also something that historically has been somewhat excluded from our studies in multiple sclerosis, which is the topic of pregnancy. I'll also be touching on breastfeeding and fertility treatments in multiple sclerosis today. I also wanted to highlight that I have 3 clinic locations. I work here downtown Chicago at the Lavin Pavilion.
Sorry,
as well
Dr.
as-
Graham, you're not sharing the presentation. Can you
I'm
click the slideshow? Yeah, just click the slideshow button.
Yeah, it's sharing on one of my screens. That's the problem. I have more than one screen.
1 second. Can you stop your share and just start it again?
Mhm.
And make sure to select the actual presentation.
Is this better?
No, can you click on, sorry,
Sorry about
display
that.
settings there? We just want to switch it so that we see the presentation and people don't see. Yeah, there. And swap. There we go. You're good.
Okay, sorry about that.
Thank you.
Okay, so I think I was starting to touch on, I have 3 clinic locations, including Lake Forest and Orland Park. All right, so here are the questions I most commonly receive about MS and pregnancy. Most of them surround the treatment that patients will receive prior to pregnancy and whether or not they can continue this while they're trying to conceive or even during pregnancy. If they cannot, they wonder when they can stop their MS treatment as we try and balance the risk of relapse and the protection during pregnancy. And finally, whether they can breastfeed and undergo fertility treatments, as I mentioned. So background on MS and pregnancy. Studies over the years have shown that MS patients have healthy pregnancies and deliveries, and most do not need a high-risk pregnancy referral. We also know that unlike some other autoimmune diseases, MS does not tend to affect fertility. And MS patients' deliveries are for the most part normal. There is slightly higher risk of C-section and lower birth weight. We know that epidural or any form of neuraxial anesthesia is safe during delivery. And we encourage our patients to talk to us if they're thinking about becoming pregnant, so we can optimize their treatment in the year before pregnancy. So here is an overview of the different treatments that a patient may be on before pregnancy. So at the top, we have our older treatments, including Copaxone and interferons. These have been studied in over thousands of patients and are known to be safe. You may discontinue them at conception, or in some circumstances, patients may continue Copaxone especially, but also interferons during pregnancy, although this is rarely done. Some of the newer therapies, which we call the B-cell depleting therapies like Ocrevus, Kesimpta, and Rituxan, are becoming more commonly used in pregnancy planning. And this is because the effect of the treatment is longer than the actual medication is in the system. So we use this to our benefit and typically stop these meds about 3 months prior to conception, although this may vary based on the patient. Our medications like Tecfidera and Vumerity, these have very, very short half-lives. And Some patients may stop this once they find out they're pregnant. Others may plan to stop it as they're trying to conceive. Tysabri and the medications like Gilenya and Zeposia, we typically stop far in advance of pregnancy because stopping right at conception can lead to a risk of rebound relapse. And then these bottom two, Lemtrada, we typically stop several months prior to conception, and Aubagio is contraindicated with pregnancy. Now, I'm going to highlight the use of these monoclonal antibodies, which are the B-cell depleters, as this pertains to some of the studies that are ongoing, two of which I'm involved here at Northwestern. So let's talk about what monoclonal antibodies mean with pregnancy. So monoclonal antibodies are the engineered antibodies of these specific treatments here, and they target specific receptors. Antibodies do not affect pregnancies in the first trimester, and that's because the placenta has yet to fully develop. It's not until the second trimester and into especially the 22nd week of gestation that there really is more active transport of these medications across the placenta. So the first trimester is about 3 months, and we know the medications listed here last in the body about 3 months. So typically we don't think that any of these will reach the baby or affect the baby while it's developing, as long as stopped prior to conception. And so for breastfeeding and MS, we know that there is protection with exclusive breastfeeding, and that this can reduce MS activity or chance of relapse by 20 to 30% with exclusive breastfeeding alone. And that's somewhere along the lines of the protection from some of our older mild efficacy therapies. Some strategies that have been used previously as well as currently to reduce risk of relapse while breastfeeding include pulse monthly IV steroids, or starting a safe but mildly effective treatment such as glatiramer or interferons. But what we're now looking at is how we can protect patients even better while they're breastfeeding, so they don't have to make a choice between a mildly effective treatment versus a highly effective treatment. So with the newer treatments like Ocrevus and then Rituxan, which is an off-label treatment sometimes used in MS, we know that there is actually little to no transfer of these antibodies into breast milk. And that's because it requires active transport of these antibodies into the breast milk. And the type of antibody that these are, which is IgG, specifically IgG1, are not actively transported into the breast milk. There are other good antibodies like IgA, which are mucosal antibodies that are transferred into the breast milk, but these don't seem to be transferred. And by that same principle, Kesimpta, which is also an IgG1 antibody, is unlikely to be transferred into the breast milk, but we don't have any data to support that yet. So I'm going to talk about the two ongoing studies I have at Northwestern and who is eligible. So the first study, which pertains to Ocrevus and pregnancy, called MINORE, measures the transfer of Ocrevus into cord blood at the time of birth, as well as looks at infant B cell levels, since we know that what Ocrevus does is deplete the B cells in the mom. So we look for the B cells in the baby. And we also look at the infant vaccine titers because we know that Ocrevus can reduce vaccine response in the mom. And so we want to make sure that the vaccine titers in the baby are also sufficient. So anybody who has received Ocrevus within 6 months of their last menstrual period and is currently at less than 30 weeks gestation is eligible to participate. And the exclusion criteria primarily surround prior pregnancy complications such as preeclampsia or preterm deliveries. And the second study, which pertains to Ocrevus and breastfeeding, is called Sopranino. And this measures the transfer of Ocrevus into breast milk, as well as also looks at the infant B cell levels and vaccine titers. So this study is for patients who are currently breastfeeding on Ocrevus, and they have started breastfeeding or started the treatment with Ocrevus between 2 to 24 weeks after delivery. And exclusions include breast anomalies or breast surgeries or the preterm delivery as well. And these studies are listed at clinicaltrials.gov for more information. And here's an overview of the visits that would occur in either study. Minore is on the top part of this graph here, and you can see there are maternal visits at twice before the birth, and then at birth, we collect the maternal and cord blood samples, and then 6 weeks later, look at the infant B cells. 1 year later, look at the infant vaccine titers, and in between, we monitor the infant's health. And then for the breastfeeding study, so Bernino below, so we don't do anything during the pregnancy itself, but then after we do look at the infant B cell levels after 6 weeks after the Ocrevus has been initiated. And finally, I'm going to touch on some other research that I have been doing on MS and fertility treatments. So in total, we have 7 studies that have looked at the outcomes of MS patients who have undergone assisted reproductive technologies like in vitro fertilization. And most of these studies have been small in number, up to only 32 patients in size. And they showed that the risk of relapse increased anywhere from 2 to 7 times after fertility treatments. A recent study in 2022, which had 225 patients, showed that there was no increased risk of relapse with assisted reproductive technology, specifically IVF. And the difference here was that in these modern cohorts, we see patients are more likely to be on MS treatment and protected throughout their fertility treatments. And our study within at Northwestern, in collaboration with Brigham, UCSF, and UPenn, showed that specifically that disease-modifying therapy was protective against relapse in an array of fertility treatments. So now that we are trying to expand on the IVF population and look at patients who are undergoing cryopreservation or egg banking, as well as treatments with oral medications like Clomid or even IUI. So you can see here, this is the kind of array of fertility treatments that are possible. And I've arranged them in theoretical increasing risk of estradiol levels. So based on the different fertility treatment, you may have exposure to different levels of exogenous hormones. And theoretically, the higher the level of exogenous hormones, the higher risk of relapse in multiple sclerosis. So from the top, we have intrauterine insemination, and this rarely uses exogenous hormones. And so this is considered to be a very safe treatment. Embryo transfer, whether from an embryo donor or from a prior stored eggs, is considered also very low risk with very low hormonal exposure. Oral ovulation induction, which is about typically 5 days of letrozole or clomiphene, is starting to increase the levels of exposure to hormones. And then we have controlled ovarian stimulation and then controlled ovarian stimulation with embryo transfer. The difference here being without the transfer, this is typically like your standard egg banking procedure. But these involve up to a couple weeks of hormone injections. And these are the ones that we really want to make sure that we're protecting patients the most for with the therapies, like B-cell depleting therapies, in order to prevent relapse around these treatments. So I thank you for your attention with this presentation. And if you're interested in participating in any of this clinical research, you may email me. And I think that's all.
Thanks, Dr. Graham. As you can see, we've come a long way from Dr. Sliwa's talk, where pregnancy was not recommended for women with MS, and now it clearly is not only a possibility, but we have ways of encouraging and assisting it. And Dr. Graham is is one of the leaders in looking at how we can do this for people with MS effectively and safely. So next, we're going to go to our next speaker. Our next speaker is Dr. Gina Perez-Giraldo. Gina is our senior fellow. She will be finishing her training with us at the end of June, and she will move to the University of South Carolina, where she will be a force in the MS program there. So Gina is going to talk to us about ethnic considerations in MS. So Gina, it's all yours.
Thank you, Dr. Cohen. I'm going to share my slides. All right, so I'm happy to be here and good morning to everybody in the audience. Today, I'm going to talk about the ethnic considerations in multiple sclerosis. And over the next 10 minutes, I want to show you why race and ethnicity matter in multiple sclerosis and why we need to think about this. So first of all, the first idea that I want to get through everybody in the audience is that suppose what we originally thought, we always have thought that MS happens more commonly in white women, and really African-American patients or Hispanic patients are less likely to have MS. This idea has actually been challenged with recent studies. As you can see over here in this table, we can see that actually African-American patients can be twice as likely to get multiple sclerosis as compared to white patients, Hispanic patients, and Asian patients. So this is very different to what we originally thought. And within that, MS is actually, the risk of MS is 3 times higher in Black women as compared to Black men. And there's actually studies even saying that Black men have a similar risk of MS as compared to white men. So women definitely are more affected, and African-American women are more affected with multiple sclerosis than people of other ethnicities. We do know that Hispanic patients and Asian patients are less likely to have MS as compared to African-American and white patients. And MS is predominantly a female disease across all the ethnic groups. That is still the case. And the clinical presentation of MS is variable or can be variable between different ethnicities. Let's start with African-American patients. So African-American patients can develop MS at an earlier age or at a later age as compared to white patients. And unfortunately, African-American patients can suffer more disabling symptoms. They have poor recovery, and they have a shorter time for a second attack as compared to white patients. The relapse characteristic of African-Americans tend to be more cerebellar dysfunction, meaning coordination, balance, a lot of cognitive problems, and the person alert with transverse myelitis. They have more occurrence of multifocal signs, meaning having like different symptoms, different areas of the body affected at the same time. It's interesting that there's increased intrathecal humoral inflammation as compared to other ethnicities. And what this means is that the production of antibodies of inflammation within the brain and spinal cord seems to be more pronounced in African-American patients as compared to patients of other ethnicities. And this is relevant because perhaps this could suggest that there could be a difference in the pathophysiology of the disease in different ethnicities. There's greater disability in African-American patients as compared to white patients, and the lesion volume in MRI, the brain atrophy in MRI, is higher among African-American patients. Let's talk about Hispanic patients. So Hispanic patients, interestingly, Hispanic patients can develop MS at an earlier age as compared to both African-American and white patients. And the interesting part of this is that that difference, that earlier age of presentation, is only seen in those Hispanic patients that were born in the US. Those patients that were born in South America or Central America and migrated to the United States after they were their teenage years, that increase, that risk of having this disease onset earlier in life is not seen, which means that there must be something in the environment leading to this earlier age of the MS onset in these patients. Also, it's interesting to know that Hispanic patients typically present with optic neuritis more often as compared to people of other ethnicities. But interestingly, that is only seen in the western part of the US. And this brings the interesting topic of Hispanic ethnicity and the heritage. Hispanic patients have different genes, like we in Latin America and South America have have ancestry from the native populations, from African populations, and European populations. So our genetics are very, very diverse. And then different countries have different percentage of different genes. There's countries that have a prevalence of European descent, countries that have more African descent, and countries that have more native descent. So for example, in the Western US, Mexican Americans tend to have a higher percentage of native descent as compared to European descent. And perhaps that is why we see differences in different areas of the country between Hispanic populations and the presentations of MS. The disability is comparable to white patients. However, in the Southeast US, actually the disability is higher in Hispanic populations. And this can be maybe perhaps access to care, or maybe it's the genetics too. In the Southeast, there's a higher percentage of Cuban Americans or people from other areas of Latin America, and perhaps that leads to that increased disability. Asian patients, interestingly, they present with optic neuritis, myelitis, and brainstem symptoms, which is among the same of other ethnicities, but they do have fewer lesions, although they are larger in the brain. And the spinal cord lesions tend to be larger and more severe, as in cerebellum is rarely involved. And there was a study from Malaysia, which is honestly one of the only studies that I could find, in which they're noting that progressive disease was less common in Asia as compared to in other areas of the world. With Native American patients, sadly, I couldn't find a lot of information. But what we do know is that the incidence and prevalence of MS is 2 times lower in these populations as compared to the others. Another interesting concept that I want to share with everybody in the audience is that minority populations do have a more severe disease course. We can see in this table about the severity score, with a higher score being worse. And we can see how Black patients have a higher score, with then Hispanic after them, then white patients after that, which means that there is an unequal burden of the disease across different ethnic groups. There's higher disability in Hispanic and Black patients. And Black patients also, in addition to that, they tend to have higher retinal damage, like retinal atrophy, and they have more brain atrophy as compared to other ethnicities. In cognition, which we do know that is impacted within all the ethnic groups, it's actually more impacted in African Americans too. So definitely, this is a group that is susceptible, and this is definitely good, meaningful data that we should be aware of. The genetics and the environment, we have known for many years that this matters in multiple sclerosis. Regarding ethnicity, MS genetic risk variance between white patients and Black patients do overlap. And it's interesting to know that this variance of these genes and the human major histocompatibility complex is similar between all the different ethnicities in multiple sclerosis. However, with the environment, Epstein-Barr virus that we also know increases the odds of getting MS, that seems to be the same between all the ethnic groups. Vitamin D, which is interesting, we have known that having a higher vitamin D level is associated with a lower risk of MS, but that has only been seen, like definitely data with white patients, and it hasn't been that clear within Black patients or Hispanic patients. And this then challenges the idea that the risk factors for MS are the same for everybody, and perhaps race and ethnicity matters also regarding what are the risk factors for getting multiple sclerosis. Another question that we need to ask ourselves is the treatment response the same, or is it different between different ethnic groups? As we know, for example, with other diseases like high blood pressure, we know that certain medications act better in different ethnic groups than others. However, we don't know that with multiple sclerosis, and that is the reason for that is that we really don't have racially diverse clinical studies. So this possible effect of race and ethnicity on treatment outcome is just uncertain. However, you could argue, you could have a hypothesis that the genetic variations that you can have in this pharmacogenetics, perhaps that can lead to a predisposition to adverse responses to disease-modifying therapy. And this could be contributing to racial disparities in multiple sclerosis. This study was the most recent one that I found. It's a retrospective study that was published in 2021, in which they took 300 patients. They were age matched and gender matched, match, and they did it in a one-to-one basis. So there were 100 patients that were Black, there were 100 patients that were white, and 100 patients that were Hispanic. And what they found is that the lag time between diagnosis and initiating DMT was about the same between all the groups, 12 months. The disease-modifying therapy that was chosen didn't really differ based on race and ethnicity, which is good. But then they did see that Black patients require a switch to a high efficacy DMT more often than Hispanic patients did, and more often than white patients did. So definitely that means that there's a difference in treatment response between different ethnicities. And overall, white patients had less disability progression, regardless of the disease-modifying therapy that was used. Regarding the disease-modifying therapy itself, studies from the earlier studies suggested that the response to treatment with interferons and glatiramer acetate might be less optimal among Black patients with multiple sclerosis. And also, there's another study that saw that the discontinuation of disease-modifying therapy, because it was just couldn't be tolerated, was higher among Black patients that were treated with interferons. There was some report many years ago in which it was thought that perhaps natalizumab or Tysabri was also not as good for patients with Black patients, but fortunately we were able to clarify this. And now we know that Black patients and white patients respond similarly to natalizumab, meaning Tysabri. And Tysabri actually very significantly improved the relapse rate among Black patients with multiple sclerosis. But overall, it's hard to definitely make statements on the response to DMT because there's just low representation of minority groups in clinical trials. And why does this matter? Why do we need to know about this? And it's because there are disparities in healthcare and MS care in patients that belong to minorities. And it's not only the biological differences that I have mentioned, but there's also differences in sociocultural factors, perception of disease, income, access, and utilization of healthcare. Sadly, we know that Black patients and Hispanic patients are 30 to 40% less likely to see an outpatient neurologist. And of those that do see a neurologist, over 30% of those patients are never going to be able to see an MS specialist. So this is definitely adding to the healthcare disparities and poor outcomes in these populations. And mortality also is different across ethnicities. In this study, that was the mortality data that was gathered from CDC, we found that mortality was higher among Black patients that were younger than 55, and after age 55, the mortality was higher among white patients. And this could be perhaps because the disease could be more severe in Black patients, or perhaps it could be because of the access of care, but we really don't know exactly. So the take-home points from this presentation is that first, MS can present in the presentation of MS and the response to treatment is variable and it varies among racial and ethnic groups. Hispanic patients and Black patients are at risk of greater disease burden early in the disease course. So these are definitely vulnerable populations. Racial and ethnic minority groups have been underrepresented in studies for MS treatments, but they are overrepresented in having socioeconomically disadvantaged group, like disadvantaged background, and they're disproportionately do face barriers to healthcare. And also, we know that patients that belong to an ethnic minority have lower participation in health research. The final message that I would like to get across is that for patients that belong to a minority group, or if you have a loved one or you have a friend that belongs to a minority group and lives with MS, it will be great to be involved in more research and be involved in more clinical trials. But this will be one of the best ways that we could close that gap in knowledge of MS within different ethnicities and also close the gap between healthcare disparities. Thank you very much.
Thank you, Gina. I'd like to turn now to Suzanne Carone from the National Multiple Sclerosis Society, who's going to tell us about resources that are available to people with MS. Suzanne?
Thank you, Dr. Cohen. Thank you for the invitation of Northwestern for me joining you today. So I would like to start with just speaking to, this is an overview of my presentation for today. So the National MS Society is working towards a world free of MS. To that end, we are guided by a very bold strategic plan to change the world and mobilize all possible human and financial resources to find solutions for everyone impacted by multiple sclerosis. So we will cure while empowering people affected by MS to live their best lives. This is our mission statement. We know now that there's nearly 1 million people in the US with multiple sclerosis. The National MS Society makes sure everyone has what they need to take back control from MS. To stand strong with every person with MS, we work to dismantle systemic racism and combat discrimination in all its forms, to remove the barriers to equitable outcomes for our marginalized communities. People connected to the society report, they are better equipped to manage life with MS, and the society is here for every person with MS, and we always will be until we find a cure. We embrace and are committed to bringing our entire MS community together, representative of all the various dimensions of diversity, so that everyone feels at home and supported by the society. So finding the best MS healthcare provider for you should be the least of your MS worries. The National MS Society eases the search by training MS specialists. We have our MS fellowship program, and we forge partnerships with healthcare organizations, such as our partnership and collaboration with the Northwestern Comprehensive MS Program. We know connecting people with healthcare providers such as occupational therapists, physical therapists, mental health providers is really so important. MS is a complex disease that requires many solutions. And the society also helps people piece it all together so they can live their best lives. We hope that we're the go-to source for accurate, actionable information about MS. And we're also growing the MS research workforce through training and funding support. Important research progress is happening every day, offering new leads toward our vision of a world free of MS. Now I'd like to move on in to talk about the society resources that are available to individuals affected by MS. So first, we have our MS Navigators, who are a nationwide team of highly skilled, compassionate professionals who work with people MS who are affected by MS on a one-on-one basis. So the Navigators serve as supportive partners to find sustainable solutions to MS challenges. We employ a collaborative person-centered one-on-one approach with the individual and finding a solution that's very individually tailored to that individual with MS and their loved ones. We provide a comprehensive service assessment. So when somebody calls the MS Society, and you see the contact information here on this slide, we provide a comprehensive assessment. We have an agreed upon plan of action and follow-up support. So if the set of needs are multiple and complex, or an adequate support system is lacking, we also refer to our intensive case management program through the Edward M. Dowd Personal Advocate Program that I'll talk a little bit more about on the next slide. We also have our self-service pages on our website that contain some comprehensive content on options to consider when seeking health insurance, seeking care without insurance, and prescription assistance, with a focus on comparing the disease-modifying therapies and those comprehensive resources designed to help with an understanding, comparing the different health insurance plans during open enrollment. So all pages have a URL shortcut to make it easy to remember. And I'm going to share the shortcuts in the chat and after I finish my presentation, so you can access them. We just want to remind everyone that it is the Medicare open enrollment period right now. So if you have Medicare and you wanted to reach out to the Navigators open enrollments from October the 15th through December the 7th, and the Navigators can work one-on-one with you to review the plans for the next year, you can just call our 1-800 number, the 1-800-344-4867, and they'll look at do a plan search with you. And so open enrollment also, just a reminder, offers a chance to reevaluate and make informed decisions about your coverage for the following year. So even if you're happy with your health insurance plan, you can explore your options for open enrollment in case your plan changes, or a new plan may be offered to coverage that's better suited for your healthcare needs. It's always important to choose coverage based on not only the monthly premiums. So for example, low premiums don't equal necessary cost savings, nor high premiums don't necessarily mean better coverage. So just considerations to take during this open enrollment period. So a case management program that I mentioned, for those individuals who are unable to independently work with an MS Navigator via the telephone or via email, or those who have some more complex needs that cannot be addressed by the Navigator, the MS Navigator will move to a situation of case management. And these services are free services that's available through the society. And with case management, our aim is to increase independent living capabilities and the quality of life for people affected by MS whose health and safety are compromised, perhaps by limited knowledge, understanding, and our ability to access our programs and benefits. So our case management service is designed to concentrate on finding solutions in the present time to the current issues the individuals may be facing and explore one's hope for the future, just to find a resolution of one's problems. So it's meant to be a time limited, lasting maybe 3 to 6 months until the services and entitlements can be addressed. So for example, maybe somebody's having some challenges, they're looking at applying for Medicare, thinking about going on Social Security disability, but feel overwhelmed by that process, then the contracted case manager might be able to provide some support in these situations. So I'm going to move now into getting into more detail about our resources and services for people living with MS. So you can discover resources and providers using a tool that we have on our website called Find Doctors and Resources. It's a search tool. You can search by zip code, and you can search specifically to locate an MS center, to locate a rehab center for occupational and physical therapy, for mental health providers, and really so much more. Partner in MS care practices, so like rehab providers, MS centers, physical therapists that we have a relationship with. If you're searching for those, there is a logo that's on our website. So the Partner in MS Care, a Center of Comprehensive Care logo just indicates that we have a strong relationship between the National MS Society and that provider. We do have services for individuals that are newly diagnosed with MS. We have our program called Knowledge is Power. It's an online free educational series for people newly diagnosed with MS and for their families. They can share the information together. This comprehensive program provides up-to-date facts, and it's available in English and in Spanish. And then you may be familiar already with our brochures. They're available on our website to download. We're not able to print them right now and mail them, but you can, if you're looking to find them and you can't find what you're looking for, you can always reach out to the MS Navigator. And then we also have our Momentum magazine that's also available for download through our website, but you can also download a Momentum app that's available to you as well. So moving into our peer support and educational programs. So we refer our peer support programs as our connection programs. So we do have self-help groups that are meeting virtually and in person throughout the United States. I'm going to highlight one specifically that just started in the Chicago area. We have a new group that's called the North Shore MS Caregiver Support Group. And they're starting to meet on the third Wednesday of the month at 7 o'clock at the North Shore Skokie Hospital. So if you're from the Chicago area, that's a new group that's available. All this information is on our website, and you can search for peer support groups by putting in your zip code and find one that's closest to you. But we also have quite a few online groups, such as our Facebook group, our MS Discord group, our ANCAN virtual MS support group. And if you're Spanish speaking, we have our Cafe Con Leche free monthly support group that's in Spanish. And then our MS Friends program, it's gone through a change recently. And to know that MS Friends it's a helpline. It connects interested individuals with volunteers living with MS for that one-on-one peer connection. They can connect via phone, the MS, and they can also connect in via email or via virtual meeting as well. And MS Friends provides a very confidential conversation, connecting directly to volunteers who have that firsthand of what it's like to live with multiple sclerosis. So individuals are paired with a volunteer, and you can connect to another volunteer by emailing peerconnections@nmss.org and connect to that program. Just briefly highlighting Happy the app is Happy is a 24/7 phone-based emotional support service. So if somebody's experiencing anxiety or loneliness, are looking to talk to a compassionate listener, they can just go to that app and be able to connect with somebody. We also have our Ask the MS Expert webinar series. It's available in English, in Spanish. It's also targeted to veterans as well. And that program that's in English is every Friday. All those programs are archived, including another program we have is our Pathways to Wellness program. This year, that program was focused on nutrition, and you can also access the recorded program on our website if you weren't able to attend the live program. Our newest program that started last fall was our New to MS program. It's held on the second Thursday of the month, and it's Navigating Your Journey is an interactive monthly virtual program. Participants who are new to MS, they come together to learn about MS, how to address the challenges of the new diagnosis, identifying strategies to help navigate that journey. Participants will learn about different types of MS, common symptoms, treatments, wellness techniques, dealing with emotions, and managing relationships. So it's hosted by a society staff member, as well as a volunteer who lives with MS and an MS healthcare professional. We also now have some programs for specific populations. So we have our Black MS experience. This was our third year to offer this virtual program. It was held over the summer, and it is available on demand. It's an opportunity to connect with others who understand the distinct experience of a life with MS as a Black person. So through some special program experiences, individuals can forge some powerful connections through this program and learn from leading scientific and healthcare experts, and also give a voice to the unique needs of the Black community living with this disease. We also have resources for Hispanic and Latinx speakers. We had our first ever Hispanic Latinx MS Experience Summit. It was an interactive bilingual virtual program for everyone in the Hispanic Latinx MS community. It's also available on demand on our website, and we will be holding another program in 2023 as well. And if you are a veteran or you know someone who is a veteran living with multiple sclerosis, we do have our quarterly Ask the Expert program, as I shared. We also have a self-help group that's led by a veteran living with multiple sclerosis also. And then I haven't highlighted, we do have our MS Adventure Camp, and it's going to be held over the summer again in person for the second time for children going into grades 4 through 12 who live in a household with someone affected by multiple sclerosis. We have 2 locations in 2022, and we may be adding a 3rd location. So campers enjoy jam-packed days of swimming, campfires, and also some MS education programs. And then we also have our pediatric MS resources that are available. We have a new program that is starting in 2023 called the New to Pediatric MS Navigating Your Journey virtual program. And it's designed for preteens and teens ages 12 through 17 who live with MS and for their parents or legal guardians. It gives families the opportunity to learn and connect with others who are also new to MS. And we also have a dedicated pediatric MS webpage, and it also lists the MS centers for pediatric MS across the country. And we do have 2 self-help groups, a teens and 20s family and friends group, and also our MS youngsters group for high school and college students with MS. This group meets virtually via Zoom as well. And my last couple of slides, I want to highlight some other opportunities to get involved with the society. There's a variety of ways to get involved, as you've heard about our programs, but we also have our fundraising events, we have our galas and luncheon, and we have our advocacy work that we do. And advocacy, that's a very empowering way to get involved and to make a difference. Our District Activist Leader program is a high-level advocacy volunteer program. The program empowers people living with and affected by MS to share their personal story. District Activist Leaders, they build a relationship through educating members of Congress about society's federal policy priorities. We call it the DAL program, and individuals engage with elected officials and their staff throughout the year, serving as an important resource to congressional offices on legislation affecting the MS community. Our MS Action Network, you're able to stay up to date on breaking news, MS issues, and ways to get involved, including responding to our legislative issues. You can sign up for that program through our website. And then we have in-district visits in the month of August and September when federal legislators are at home in their community, and you can schedule time to be able to meet with them and discuss our issues. You can provide testimony on a state level and also get involved in our state action days that we have. And then our public policy conference is I have really appreciated attending that event. It's virtually now, so everyone has access to the program. For the past couple of years, it's been virtual, and we advocate on federal issues, and the issues we advocated for this year was on MS research funding and affordable health insurance and prescription drugs. And the MS activists this year played a very key role in the passage on prescription drug and health insurance legislation. And also becoming involved as a peer volunteer. We continually are looking for peer volunteers, whether as a self-help group leader or through the MS Friend program as some examples. And I just want to talk a little bit about our events that we have. We have our Bike MS event. It's held across the country. So if you're attending from other parts of the country, it's our largest fundraising cycling series in the world. We have about 75,000 cyclists and more than 6,000 teams who ride together to change the world for people with MS across the nation. This year in Illinois, there is some new information. The Bike MS will take place the weekend of June 24th and 25th at Cooper's. It's KUIPER Farm in Maple Park, Illinois. And then we have our MS event, which is our largest gathering in the MS movement, and it raises funds to change the world as well for people living with MS. It celebrates really the resiliency for nearly 1 million people living with MS in the US. And the Walk MS events are communities across the country. In Illinois, we have events in Chicago, Naperville, Deerfield, Roselle, St. Charles, Orland Park, Lake in the Hills, Oak Lawn, Peoria, and in Southern Illinois and Edwardsville. And you can access tools on our website to be able to register for the walk to participate, but you can also visit our website to become involved as a volunteer with both of these events. And I just want to acknowledge that Northwestern has annually been recognized not only as a presenting local sponsor of Walk MS in Illinois, but also as a top corporate team since 2007 with over 300 team members, raising over 50,000 cumulatively. So we invite everyone, if you would like to join the Northwestern Medicine Walk MS team or form your own team in 2023. And so these great events are all also, as I said, have opportunities for volunteering. So I'd like to end my presentation. I thank you for your time.
Thank you, Suzanne. I think, as you can see, the Society offers a wealth of sources of information and assistance to people with MS. And I would strongly encourage any of our audience who have not already connected with the Society and become aware of what they offer to do so. You'll definitely benefit from it. So once again, I'd like to encourage people to submit their questions using the Q&A icon. We're going to take a 10-minute break now, and we'll resume at 11:15. So please, again, submit your questions, and we'll get to questions at the end of our program, and we should have plenty of time to address any of the questions that you have. This slide shows you the icon, so we will see you in about 10 minutes. So I'd like to welcome all of you back. I see that you've all been busy and we have quite a few questions now that have been entered into the chat, so that's great. We're going to move on with our program. And our next speaker is going to be Dr. Elena Grubentsiakova. And Dr. Grubentsiakova is going to talk to us about multiple sclerosis and the COVID pandemic, implications for those who are immune suppressed. So Elena, it's all yours.
Good afternoon, everyone. Thank you so much for joining us on this cold morning. And today we will try and talk a little bit about the implications of the pandemic for those people who live with multiple sclerosis and are taking immunosuppressive medications, or perhaps also have other multiple risk factors for having potentially more severe COVID. And I'm hoping to answer some of your questions in terms of the vaccine safety, the necessity of vaccines, and ultimately the biggest question of all, with the pandemic being such a shifting sand under our feet and the viruses continuously changing and all the media intermittently telling us about immune escape, about Paxlovid rebound, all of this alarming data. How do we internalize that? And what does it mean in terms of us getting vaccines? Are they still effective? Do we need them? Are they safe? And what do we do ultimately if we do become infected? So bear with me. We're going to start with just really some basics and move on from there. So first and foremost, I want to talk about a myth that MS is an immunocompromising condition on its own. I would say that while some people with multiple sclerosis who have high degree of disability are certainly at a higher risk of infections and complications from infections, multiple sclerosis itself as a condition does not make you immunocompromised and does not make you at a higher risk of infections or more severe infections. So for example, a 35-year-old woman with multiple sclerosis on her own by default is not immunocompromised and by default is not at a high risk of infections or more severe COVID. But at the same time, a 65-year-old person with multiple sclerosis who may be using a walker or in a wheelchair, certainly by the nature of the two risk factors, older age and the disability, is at an increased risk of infections and more poor outcomes with an infection. In the context of multiple sclerosis, being on an immunosuppressive or a powerful immunomodulatory medication, really what makes you immunocompromised or essentially weakens your immune system and its ability to perhaps fight the virus. So it may take you a little bit longer to recover, or in some instances, it may impair your ability to adequately respond to the vaccines. So in other words, you get some protection, but you may not get as good of protection as others. So what are some of the factors, just general factors associated with a higher risk of more severe COVID? Turns out they're very similar for people with multiple sclerosis as for people without MS and general population. So age over the 65, so being older, we know throughout the pandemic, the hospitalization rates, mortality rates have been extraordinarily much higher in people of older age. And that holds true also for anybody who lives with multiple sclerosis. You are at a higher risk if you are older. Male gender has a slightly higher incidence of severe disease, and African American race is also one of the risk factors for potentially more severe disease with COVID. A high degree of disability. And in reality, it doesn't have to be associated with MS. A person who was involved in a car accident and is in a wheelchair, they are likewise at a higher risk of severe COVID, just simply based on the fact of their weakness and disability. Being overweight or obese is also an important risk factor for potentially more severe COVID. Chronic lack of physical exercise, inactivity, sedentary lifestyle, also taking steroids chronically or frequently. So for example, if some patients are utilizing steroids for some reason on a monthly basis for years and years, that would be a major risk factor for severe COVID. having other chronic conditions such as heart disease, lung disease, cancer, kidney disease, diabetes. Those are major risk factors for severe disease as well. And of course, being on an immunosuppressive medication. And being on an immunosuppressive medication alone doesn't always mean that you're going to have severe COVID, but it slightly increases your risk, particularly if it interplays with other risk factors that may be inherent to you. So for example, a 30-year-old on an immunosuppressive drug versus a 65-year-old with diabetes and obesity in a wheelchair on an immunosuppressive drugs. Those two people may have one has slightly increased risk of severe COVID, and the other person has a significantly higher risk of severe COVID. So what are some of the medications that are immunocompromising versus non-immunocompromising? This is just a brief overview. So if you're someone who is taking Avonex, Copaxone, Glatopa, which is glatiramer acetate, or Rebif, or Betaseron, or Plegridy, these medications are not immunosuppressive. They are not associated with higher risk of infection or higher risk of COVID. And you should be able to get vaccinated against COVID at any point on these medications, and you should be able to make a really good immune response. So for those people taking these medications, you are not by default, because of these medications, you are not at a higher risk of severe COVID. Unless certainly you have some other risk factors, maybe it's obesity or diabetes, etc. These medications in studies slightly increase risk of infections, but overall in studies of COVID do not appear to associate with significantly higher risk of severe COVID disease or higher risk of hospitalization. These are dimethyl fumarate, Tecfidera, Vumerity, Tisabri. Tisabri is generally not a systemic immunosuppressive drug. It prevents the immune cells from getting access into the brain, but Tisabri does not destroy your immune system. You still have your immune system. So if you're on Tisabri, you're pretty safe during the pandemic. Also, Aubagio, likewise, while it's only minimally increases risk of infections, is generally a very safe medications to be on during the pandemic. Now, for those people who have more active multiple sclerosis and who have to be taking medications that are stronger and more immunosuppressive, some of these medications indeed are more immunocompromising. They certainly modulate your immune system more, and some of these medications may increase your risk for potentially more serious COVID. And that basically means that the importance of vaccines for you is even higher. That's number one. And number two, that if you are one of those people and you have been exposed to somebody who is positive for COVID, you have to get tested in about 5 days after exposure, even if you are asymptomatic. And then obviously, if you develop symptoms, you need to immediately contact primary care doctor or be seen at urgent care so that you can get treated promptly, because you may have a high risk of developing a more severe form of COVID. Not always, but it's really just in relative terms a risk. It is important to notice that Gilenya, Ziposa, Mayzent, Ponvory, some of the immunosuppressive drugs that can decrease effectiveness of vaccines, so can Ocrevus, Kesimpta, Rituximab, Alemtuzumab, and Cladribine, which is Mavenclad, which is associated with immunosuppression that is more transient during the first couple of months, about 3 months after each cycle of treatment, and then the immune system reconstitutes. So what about IV steroids? I really always talk to my patients about the fact that IV steroids have a place, a good place in true MS attacks. And while they can speed up the improvement of symptoms in a true MS attack, meaning that you're having a new lesion, you just developed new neurological symptoms, IV steroids ultimately do not really change the outcomes. So for a patient who is really high risk for COVID or an infection, it's always a discussion between you and your physician about the risks versus benefits of IV steroids. In other words, we have to dissociate ourselves from this default mode of thinking that anytime I have some sort of worsening of something, I need to go to the emergency department and get IV steroids. These actually can be dangerous, more dangerous than good in some instances. For example, early in the pandemic, when we looked at the outcomes of people who received IV steroids and then within a month from IV steroids happened to catch COVID, we actually saw that the risk of severe COVID disease and hospitalization went up nearly 2 to 6 times. So that's major. So in other words, yes, steroids have a place in treatment of acute flares, but we also have to be extra vigilant, and we have to always discuss with our providers the risk versus benefit. So in other words, if a patient with multiple sclerosis truly has an attack and has severe weakness in the leg, yes, absolutely, they need steroids because that is a disabling attack. However, if the same patient had an attack that was mild numbness and tingling, of course, it's not minor to you as a patient, but if you also have bad asthma and diabetes and obesity, and the question becomes, you should discuss with your physician, IV steroids for 3 to 5 days. Is it absolutely necessary in this mild relapse? Will it change your outcome? And what is the risk versus benefit? So I welcome everybody to always make sure that you discuss when and if IV steroids are truly necessary. So how do we protect ourselves against COVID? You know, over the past few years, we've been doing all of these vaccines, but we are continuously bombarded by mass media that says immune escape of this new variant, that new variant. Are vaccines even effective at this point? So to date, vaccines are proven to reduce the risk of hospitalization, severe illness, and mortality. And no, the vaccines will not protect you from catching COVID. You probably will catch COVID. You can catch COVID multiple times, as many of you already have probably done. But really the goal of these vaccines is to reduce the risk of severe illness, reduce the risk of hospitalization and death. And that is exactly what these vaccines actually have been doing a really good job at. Not a perfect job, but nothing in terms of treatments and nothing in medicine and science is ever perfect. So we still recommend the initial series of vaccines if you have not completed it. And that's the primary series of like first dose of Pfizer or Moderna, second dose 3 weeks later, and then the third dose at least 4 weeks after. Assuming that most of you have had these vaccines, what you need to know is that there is a new booster for the past couple of months. It's a bivalent updated booster that is based on the circulating variants this summer, BA4 and BA5. And some of you could say, well, wait a minute, isn't BA4 and BA5 now going away and other variants are emerging? It is true. This is the trend of the new variants. And if you look at the last column on the right, this is November. So if you can, if you look at it closely, you will see that BA5 that earlier was predominant in July, August, September is now less than 30% of cases. Instead, we are having new emerging variants such as BQ1, BQ1.1, BF7. For example, the two variants, BQ1 and BQ11, they are they are mutations of the BA5 as the ancestral strain. So luckily, the Moderna and Pfizer, both of them, the preliminary data show that the vaccines, the bivalent boosters that have been available over the past few months do still have some level of protection and neutralizing activity against these emerging variants. Now, we also hear in the news a lot the term immune escape. So these viruses cannot fully escape the immune system. When people say immune escape, they really mean that the antibodies from the vaccine are becoming less effective. And while it may be true, you're still getting the T cell responses that may be cross-protective for different strains. When you get a vaccine, there are two main responses. B cells make antibodies, and those antibodies, yes, they may lose that 100% beautiful effectiveness. Well, the truth is they're never 100%, right? But there's also T cell responses, and those T cell responses are equally important, but mass media generally doesn't talk about it as much. But T cells are very difficult to evade. So when you get a vaccine, it's not just antibodies that you make, it's also the T cells that you prime, and your T cells become specialized in killing the virus. So if you look at these percentages right now in the United States in November, BQ1.1, BQ1, and BF7 are really over 50% of what's circulating right now, and BA5 is about 1/3. And so these three strains are becoming dominant. However, I also really urge you to look locally in terms of what's happening in your state. So for example, the right column for Illinois in November, BA5 is still not completely gone. So, I mean, it's over 60% of cases in Illinois, but, the other ones are becoming more and more prominent as well. And if you look below, you will see that the new variants that are emerging right now, they basically are becoming more and more prevalent. So getting vaccinated with bivalent booster does make sense. So what about the timing of vaccines while on a B-cell depleting treatment like Ocrevus, Rituxan, or Kesimpta? So in the ideal world, if you think about the rituximab and Ocrevus, it's an infusion that's given every 6 months, right? So you deplete B cells, and in 6 months, towards about 6 months, the B cells start reemerging slowly. That's why we say that towards the cycle of 6 months before your next infusion, the time frame when your B cells have a chance to reemerge a little bit, 3 to 4 weeks before the next infusion is the most ideal time to get vaccinated. However, even at the month 3 or 4 or 5, it's fair game to go ahead and get vaccinated. In other words, don't pay attention to me saying the ideal. The ideal may not always play out with your schedule. So what that basically means is that if you got Ocrevus or Rituxan in August, my goodness, should you really wait September, October, November, December to get vaccinated? Absolutely not. Because even if you get vaccinated 4 to 6 weeks after your Ocrevus or rituximab, it will still boost your immune system responses, boost your T cells, and you will get benefit. In other words, if you just got your Ocrevus in August and September and you didn't get to do all of your boosters or flu shots, do not wait until January or February, month 4 or 5. So there's an ideal world scenario where you get these vaccines 3 to 4 weeks before your infusion, but we also have to be cognizant that you cannot wait, certainly for half a year, to get vaccinated. So you really can do it 4 to 6 weeks or so after the infusion if you are in that setting. With Kesimpta, because Kesimpta is an injectable once a month, you actually if you're on Kesimpta, you can get your vaccine at the end of 4-week cycle, and perhaps you can try to either continue your Kesimpta or skip the next injection, but then in 3 weeks, resume it. So many of you may know about Evusheld. So Evusheld is a pre-exposure prophylaxis. These are long lasting antibodies, and it's a little shot, intramuscular shot that you get every 6 months. And these long-lasting antibodies have been offering really nice protection against severe disease of COVID to those who are immunocompromised, who may not be able to get a good immune response. And, during the summer, they certainly retained neutralizing activity against Omicron variants BA4, BA5. But now we are seeing that as the variants are changing, Evusheld may offer less protection against the new Omicron strains. And the current 3 strains that are starting to take a strong foothold in the United States, BF7, BQ1, BQ11, are resistant to Evusheld. And this is important to know because if you look right here in Illinois, at least in the state of Illinois, and you have to look at your own state, we still have plenty of BA5 for which Evusheld is effective, but we also are having an increased incidence of the other variants against which the ones that are actually resistant against Evusheld. So if you have Evusheld scheduled and you live in Illinois, you still should get it, but you should reevaluate it by discussing with your physician in the upcoming months, or whether it is still recommended, whether you need to repeat it. And then of course, CDC will be updating their guidelines, I expect to be soon, because as these viruses that are resistant to Evusheld BF7, BQ1, BQ11 are gaining a strong foothold, they probably over the next few months likely probably are going to be pulling back on Evusheld. CDC has not communicated that yet. So for now, if you were planning to get it, you should still get it if you live in the state of Illinois, but you should always discuss with your physician the decision of holding it until CDC officially tells us not to pursue it anymore. So it is also very important to know your COVID-19 community level. So what you can do is you can go to your health department website that is local to your state, or you can go to the CDC website and just basically look at CDC community level. And if you type in your state, your county, it will show you, for example, what is the level right now in your community? What is your risk of COVID infection of when you are out and about? So for example, right now in the Cook County in Chicago, in Illinois, the risk is overall low. Now that risk may go up as the cases soar later during this winter. Why do we need to know what is the risk? So that you can accordingly know whether it is safe for you to be out and about in the groups of people, or because as the virus becomes again more prevalent, you may choose to wear masks even more, or even in some high risk scenarios wear an N95, or even try to reduce exposure to groups of people. So what to do when you have become infected with COVID? If you have become infected with COVID, you really need to contact your primary care doctor and leave an urgent message for their nurse, or be seen at an urgent care. Why do you need to do that? Well, because if you are somebody who is taking an immunosuppressive drug, or you are somebody who has multiple risk factors for severe COVID, you need to be treated. And if you need to be treated, that means that the treatment needs to be administered the sooner the better, within the first 5 days of infection, ideally. So because some of the monoclonal antibodies are now failing in controlling some of these new variants, we are really shifting more towards Paxlovid or Lagevrio, so the oral treatments, and or remdesivir for those who are hospitalized. These medications continue to be effective at reducing the risk of mortality, the risk of severe illness. At the end of the day, if you are having trouble reaching your primary care doctor, or obviously always communicate with your MS provider as well, or if you for some reason cannot be seen at an urgent care, or there isn't one close to you, there is a federal government initiative called Test to Treat, and a lot of health departments and CVS pharmacies participate in it. And you basically would type into Google Test to Treat, and it will open up a locator for pharmacies and places that participate, where a pharmacist, if you bring them a positive COVID test, or if they can test you on site and you're COVID positive, they're actually able to prescribe you Paxlovid or whatever is appropriate during that time. So please, try to, if you have not received your bivalent COVID booster, try to do it. Communicate about the right timing with your provider. I'll be here for more questions, of course, but these vaccines have been safe for MS patients. We are not seeing increased risk of relapses. We are not seeing increased risk of any specific side effects. So I do, urge everyone to get an updated booster and to continue being vigilant during this season. And I wish everybody to have safe and happy holidays. And I'll be here for questions later. Thank you so much for your time today.
Thank you, Elena. We're going to move to our next speaker, Dr. Roman Balabanov, who's going to talk to us about the current status of hematopoietic stem cell transplantation in multiple sclerosis. Roman?
Thank you, Dr. Cohen. And thank you everyone for attending our meeting today. And I also would like to acknowledge the help of the National Multiple Sclerosis Society for supporting this event. The topic of my presentation is hematopoietic stem cell transplantation in multiple sclerosis. So this is a very interesting and yet difficult topic, and I'll do my best to explain it to you. And so bear with me. I cannot advance the slide. Okay, here we go. So let me start with a few definitions. Multiple sclerosis is an autoimmune disease driven by two immune cell types, T and B cells. And the goal of the hematopoietic stem cell transplant is to destroy the immune system that causes multiple sclerosis, and then to reset or reboot the normal, the immune responses back to normal. The two commonly used treatment strategies. So first is to completely ablate the immune system with a single treatment of chemotherapy. And this chemotherapy, as I said, can be myeloablative, the one that destroys the entire bone marrow. And the second one is non-myeloablative. This treatment spares the bone marrow, but selectively destroys the immune system. And everything after this chemotherapy treatment is followed by immune reconstitution. So hematopoietic stem cells are bone marrow derived pluripotent cells. So they give rise to all the clones in the blood. But those cells are different from the embryonic or the neuronal stem cells. So those, the hematopoietic stem cells, as I said, they reside in the bone marrow, and they are harvested prior to administration of the chemotherapy, and then they're returned back to patients after the chemotherapy. And the overwhelming interest, I think, in hematopoietic stem cell transplant really comes from the fact that it creates a very unique model of cure for multiple sclerosis in other autoimmune diseases. So the science behind hematopoietic stem cell transplant has three dimensions. So first, the transplant tries to address some of the common problems that we see with multiple sclerosis. So all immunotherapies that we have, though with increased efficacy, they're still partially effective. And the reason they're partially effective is that they target steps of the immune response that may be absent, sometimes present, perhaps over time. The significance of those steps of diminishing significance. And for this reason, we see responders and non-responders to our disease-modifying therapies. It's well known that MS early on responds well to this to MS therapies, and later on that efficacy of the medication decreases. There are also some dose and time-dependent limiting factors, there are complications, adverse effects, neutralizing antibodies. But what is really behind, I think, behind the partial efficacy of disease-modifying therapies and the associated limited factors, this is that we really do not understand well the difference between the immune responses, which are protective against viruses or cancer, and the autoimmune responses which drive autoimmune diseases in MS in our case. What we really have at the moment is the high efficacy treatments. They are associated with more side effects. So there is a positive correlation between efficacy and adverse reactions. Some of our medications are associated with opportunistic infections, as well as with secondary autoimmune diseases. And as Dr. Grebenc-Sikova mentioned to you earlier, we have vaccination or infection-related issues with some of the medications. And importantly, currently, we do not have a cure for multiple sclerosis. The second aspect of the science behind hematopoietic stem cell transplantation is the phenomenon of acquired immune tolerance. So this phenomenon is one of the most important experiments that has ever been performed in the field of immunology. And the person who did it, Macfarlane Burnet, was awarded the Nobel Prize for Immunology in the 1960s. So I would try to explain this experiment In a very simple terms, but this is highly relevant to what we think is behind the efficacy of hematopoietic stem cell transplantation. Imagine that you have two mice, so a white mouse and a black mouse, and it has been known for decades that skin transplantation between those two different strains, and they're genetically different strains, at mature age always fails. But what he discovered that if he administers donor cells, and those are blood cells, in an immature, just born animal, this animal becomes tolerant to the foreign cells. And later in time, when the graft or the transplantation is performed, actually the graft will survive. So the way this is relevant to us is, one is this type of early exposure of the immune system to foreign antigens or foreign tissue bypasses some of the genetic predispositions that determine what molecule should be tolerated and what tissue should be rejected. In going back to MS, so it's well known that human immune system develops very early in life. The all T regulatory cells that orchestrate the responses in patients are actually generated in the first year of life. Central myelin, on the other side, develops very slowly, and in fact does not peak its activity in late 20s. Some patients and individuals still form myelin in their early 30s. So there is a mismatch in the timing between when the immune system develops and when the myelin develops. And this alone, this timing mismatch, kind of creates this inadequate immune tolerance and allows the existence of autoimmune demyelinating diseases. So what we hope is that post-transplant, this newly developing immune system will be exposed to natural proteins, which hopefully would diminish the propensity and the autoimmune predisposition for multiple sclerosis. And the third point behind the theory of hematopoietic stem cell transplant is the effect of immune rejuvenation. So it's known that aged mice do not repair demyelinating lesions well. And in contrast, young mice actually repair those lesions quite efficiently. And this has been a problem in experimental MS models that, unlike patients who develop the disease later in life, experimental animals actually repair quite efficiently their myelin. And so this experiment performed about 15 years ago demonstrated that in a parabiosis model, so this model basically is based on linking the blood vessels of a young mouse to an old mouse with a directional influx of blood. And so then the old mouse would be injured. And so what this experiment showed that this influx of young blood, if you will, allows a very effective myelin repair despite the old age of the mouse. So the mystery behind the young blood effect is the presence of the so-called M2 monocytes. And what they do is that they're able to remove myelin, the myelin debris, or the injured cells without causing any significant inflammation. So the actual term is non-inflammatory phagocytosis. So the hope here is that after transplant, the rejuvenated immune system is likely to repair MS lesions more efficiently simply because of the enrichment of those M2 macrophages that follow the transplant, and clinically to result in neurological improvement. And this as a phenomenon is more relevant and tends to work better in acute lesions, in relapsing lesions in animal models, and less so in old scarred lesions. So here is an outline of all the treatment, the most important treatment steps of hematopoietic stem cell transplant. So the whole process starts with a screening visit. And there are 2 points of the screening visit. One is to confirm the diagnosis of MS, to go over the symptoms and the type of disease the patient has, the duration of the disease, and the level of disability. And typically the criteria for transplant would include relapsing remitting MS, active disease, meaning new relapses occurring within a year or 2, new lesions appear on the MRI, relatively short disease duration within 10 years after the diagnosis, and age of the patients less than 50 years. The second point of the screening visit is about to evaluate for medical problems, typically infections, tuberculosis, hepatitis, to assess the function of the heart and the liver, and as well as to rule out cancer in other autoimmune diseases. So once the patient is admitted for the study, accepted, the most immediate step prior to transplant is mobilization and harvesting of the stem cells. And this goes for a few days. And then the patient is admitted to the hospital. And the first step during the hospitalization is to destroy with a high dose cytoxin, or being, this is the myeloablative treatment, to destroy the immune system. As you see, other cell types actually suffer as well, including the platelets and the red blood cells. And once reliably the immune system is destroyed, hematopoietic stem cell transplant gathered from this point on will return back to the patient. Patients typically receive about 20 million cells. And they're allowed to engraft for about a week, and then they're stimulated towards proliferation and differentiation by a hormone called colony stimulating factor, granulocyte colony stimulating factor. Patients will remain in isolation, so this is done in a transplant ward. And once the white blood cells increase, and specifically once the neutrophil count reaches point of 1,000 cells per microliter, patients are discharged. There's some other treatments that they receive. This is to improve either the engraftment of the cells or to prevent infections during the acute phase. And following the discharge, the patients would receive antibiotic prophylaxis that goes for 6, 7, or 9 months, depending on the risk for infections, the recovery of the white blood cells over time. So what do we have in terms of clinical evidence for the efficacy of the hematopoietic stem cell transplantation? So clinical trials in transplant in MS and autoimmune diseases have been performed since the 1990s. But perhaps the most interesting and relevant to this presentation are those 5 clinical trials performed since 2015. And all studies showed one thing. There is a significant impact on the disease relapse rate, so close to 60, 70%, and significant impact on progression, holding progression in neurological disability. So I would like just to give you a few examples. So you can look at the Canadian study, activity-free survival, 69.6 at 5 years. The NIDA, so this is an outcome, meaning no evidence for disease activity in the Australian study at year 3 was about 60%. So those patients will have no relapses, no new lesions, and no progression in their disability. So we are part of this MISS study, and I just would like to show you 2 very interesting aspects that were discovered during the study. So the very first thing that we've noticed is that it's not only patients have no or fewer future relapses, but they actually improve in terms of their neurological disability by almost a point compared to their baseline. And because this was a study that was a randomized study comparing the non-myeloablative stem cell transplant versus disease-modifying therapy that were available at the time, what we saw is that the percentage of patients in the hematopoietic stem cell transplant group who reached the state of need and no evidence for disease activity was 78.5%. Patients who are in the disease-modifying therapy, the NIDA proportion was only 2.9%. So that showed, the study demonstrated this massive positive impact of the hematopoietic stem cell transplant. The adverse effects were mainly inpatient infections, but the overall infection rate of 5 years was very similar between the stem cell transplant and the disease-modifying therapy groups. There are several autoimmune diseases that result in the transplant. There are a few patients who develop hypothyroidism, one hyperthyroidism, and a few other patients who develop idiopathic thrombocytic purpura. And there were no deaths or cancer during the study. But remember, studies are done in a very controlled setting. So the real life experience with the transplant can be different. And I just want to bring this just to point here that mortality is actually, it's something that can occur. So this is a very complex procedure, if you will, that has to be done in qualified centers. I wanted also to mention that there is one still open hematopoietic stem cell transplant in MS. It's called BEAT-MS. It involves 17 centers in US and one in the United Kingdom. So it's a multi-center, a rather blinded study, randomized, and it was a phase 3 clinical study sponsored by the National Institute of Health. And so it's just a 2-arm study. So it's comparing the efficacy, safety, and the immunological effects and the cost effectiveness of transplant to the best available therapy. So those are the high efficacy therapies. It involves 156 patients and is going to continue for about 6 years. So the conditioning regimen is myeloablative. So patients who receive BEAM-ATG treatment. The criteria for admission, for inclusion, so younger patients, 18 to 55, the study would include patients with relapsing, remitting, and secondary progressive. However, those patients from the both forms of the disease should have continued relapses or MR activity despite treatment in the past 2 years. So as I said, the study is still open, is likely to complete enrollment in October 2026. And the study, because of the follow-up needed for 6 years, is likely to continue all the way until 2029. And I would like to conclude with the recommendations of the National Multiple Sclerosis Society that were first published in JAMA Neurology in 2020. But you also can find those recommendations on the website of the National Multiple Sclerosis Society. So the society believes that transplant may be useful treatment in patients with relapsing remitting multiple sclerosis that have a breakthrough disease. And this would be despite treatments of high efficacy treatment or in the presence of contraindications for those treatments. The best candidates are those who are younger than age 50 and have a shorter disease duration. And as I mentioned to you, the recommendation is this treatment should be done in centers with substantial experience and expertise. And preferably, actually, those centers should be certified by, in the US, this would be the foundation for the accreditation of cellular therapies. And in Europe, they should be the European Bone Marrow Transplantation Society. And I think with this, I'm done. Thank you so much for your attention. I'll be happy to take questions later on. Bruce?
Thank you, Roman. Thanks for that presentation. So we're going to move now to my presentation, which is here. See if I can get this up. All right. So I'm going to talk to you now about progressive multiple sclerosis and try to give you a current perspective on where we are with.
Dr. Cohen, you're not sharing your screen right now.
Do you see it now?
No,
Okay, I do. So I'm not sure what's happening. All
you need to share it on Zoom. I can share your slides from my end if you just want to let me know.
right, go ahead. All right, are you seeing it now?
Yes.
Okay.
Let me know.
Yes, Bruce, yes.
You can see? Okay. All right. So I'm going to, just to make sure that we're all thinking about this the same way, I'm going to start by describing the clinical courses of MS as we typically do. So we refer to relapsing remitting MS as episodic symptoms, such as seen by these bars, in which there is a period of symptoms followed by a period of recovery. And in between, there is no apparent activity. Sometimes the recovery is complete. Sometimes the recovery is partial. If we look at MRI scans, we can see that when there are clinical events, the MRI scans show activity, but sometimes even when there are no clinical events, the MRI scans still show activity. These are new lesions. And when these new lesions occur, we consider these to be subclinical relapses. Now, when we talk about progressive multiple sclerosis, we talk about the gradual worsening of symptoms independent of relapses. And this can occur at varying rates. It can occur for a period of time and then appear to be stable and then recur. Or there can be superimposed relapses that occur with it. When the initial presentation of the disease is slow, gradual worsening, we refer to that as primary progressive MS. When the slow, gradual worsening is preceded by typical relapses and remissions, we call that secondary progressive MS. Now, most people, about 90%, present with relapse onset MS or relapsing remitting MS. However, about 1 in 10 presents with progressive MS. And we are now starting to find out that there are people who get MRI scans for symptoms that have nothing to do with MS, for example, headaches, who, when we see their MRI scans, they have findings that look like MS. And we refer to that as RIS, or radiologically isolated syndrome. What we see over time is that relapses and new MRI lesions that indicate inflammatory activity tend to decrease. On the other hand, the size of the brain and the spinal cord tends to decrease. Part of this is due to aging, but it decreases at a greater rate than aging would lead us to expect in people with MS. On the other hand, clinical disability may increase, but this is very heterogeneous, so that in some people, there is very little increase in clinical disability, while in other people, clinical disability occurs to a greater frequency and typically, usually, as they age. There are a few people in a small group in which clinical disability occurs rapidly within the first 5 years. Now, although these clinical phenotypes appear to occur sequentially, the underlying processes which can lead to later disability are likely present from the beginning of the disease. And we also think that they're similar in people, whether they have primary progressive MS, in other words, progressive onset MS, or whether they have secondary progressive MS. One line of evidence that supports this is the fact that when we look at these people who have evidence of MS on their MRIs but have never had symptoms, we find out that over approximately 10 years, about half of them will develop symptoms typical of MS, and 10% of those people will develop primary progressive MS or progressive onset MS, while 90% will develop relapses typical of relapsing onset MS. Now, we don't know the cause of MS, the underlying cause of MS, but currently our hypothesis is that individuals who have a genetic susceptibility encounter environmental factors. Now, right now, the most important of these environmental factors is believed to be Epstein-Barr virus. And recent evidence suggests that everybody with MS has evidence of immunity to Epstein-Barr virus, which indicates exposure to the virus. But since 95% of the population overall has evidence of immune responses to Epstein-Barr virus, clearly not 95% of the population develops MS. So additional factors are necessary for MS to occur. When those factors are present, immune responses are activated, which target central nervous system, or in other words, brain and spinal cord, myelin, and the cells that make myelin, oligodendrocytes. Now, these immune responses involve both arms of the immune system, the systemic or adaptive immune system, in which the immune system is sensitized outside the brain, as well as the innate branches of the immune system, which occur inside the brain. The result of this is a process that is self-sustaining and results in further damage inside the brain. But this damage occurs both because of inflammatory and also non-inflammatory mechanisms. So we understand the pathology of relapsing MS fairly well. We understand that the systemic immune system is activated and that cells that are activated in the periphery pass into the brain and cause inflammation. And we have multiple medications now which are active against this form of the disease. On the other hand, we don't understand the pathology of progressive MS nearly as well. We do understand that there is inflammation that is sequestered within the brain in a compartmentalized fashion where it's less exposed to our current medications. And we know that the innate immune system is activated, and these appear to be the primary drivers of inflammatory damage in people with progressive MS. We also know that there are a number of non-inflammatory disease processes, which include loss of the protective functions of myelin, exposure to toxic molecules, and impaired energy metabolism, which is necessary to maintain the integrity of nerve cells and nerve fibers. And in addition, there's a failure of normal repair. So we don't have normal remyelination and normal repair mechanisms. And this is likely the result of inflammatory and non-inflammatory mechanisms. So when we look at inflammation in the brain in people with progressive MS, we find that it occurs in the membranes which surround the brain, which are known as the meninges. And we find that it occurs diffusely throughout the brain. So even in areas that are not evidently abnormal on routine MRI scans, other more advanced imaging techniques show us that there's activation of the innate immune system diffusely. And we believe that damage in progressive MS is occurring both from inflammation that occurs at the edge of chronic active plaques and also remotely from the sites of inflammation that occur, where it likely involves soluble factors which are produced by the inflammatory cells and which activate elements of the innate immune system and other mechanisms of damage. If we look at some of those non-inflammatory mechanisms, what we see is that when nerve fibers are damaged, they elaborate new ion channels or pores, which allow them to maintain their conduction, although they do so more slowly. But in order to maintain these ion gradients, they need to have more energy. And this causes a metabolic stress, which can lead to energy failure, impair the ion exchange, and ultimately lead to the destruction of the nerve fiber. When remyelination occurs, it can restore more efficient conduction, but the conditions for this have to be right. In chronic plaques, glial cells called astrocytes inside the brain scar the areas around the zones of destruction and prevent remyelination and axonal repair. Over time, this stress may cause more axons to succumb. This may be a result of remote damage and later degeneration. It may be the result of increased stress as some axons in a pathway succumb, overloading the other axons that remain. But eventually, in time, there may be a sufficient destruction of these nerve fibers that it exceeds the reserve threshold for maintaining function. And that's when we see clinical worsening. And as I mentioned, that period of time is very heterogeneous. So in some populations with progressive MS, that may be very modest, and in others, it may be more significant. So how do we address this? So obviously, in general, we would like to prevent further damage. We would like to have medications that would do that. We would like to maintain function. We would like to optimize function and prevent further deterioration. And ideally, we would like to be able to restore or repair areas of damage. So can we do anything now to reduce the risk of progressive MS? So we have good evidence now that for people with relapsing onset MS, early initiation of treatment reduces or delays the risk of later disability progression. We also have evidence accumulating that this is also true for people with progressive onset MS. In people with relapsing MS, initial use of more potent immune therapies from the beginning appears to be more effective in terms of subsequent disability over 5 to 10-year time periods. But we don't yet know if this is the best strategy for everyone. And so for people with very mild onset MS, a different strategy may be effective, and that's being tested now in clinical trials. For those people with progressive onset MS, there is one medication, ocrelizumab or Ocrevus, which has been shown to reduce the risk of worsening by about 25%. The benefit occurs mostly and best in people who have evidence of inflammation on their MRIs when they start treatment. And it appears to be greater in younger individuals, although its effectiveness in older populations is currently being tested. For people who start out with relapsing MS and then go on to develop secondary progressive MS, siponimod or Mayzent has been shown to reduce the risk of disability progression by about 21%. Again, the benefit is best in people with evidence of inflammation on their MRI scans and who are still having relapses. It may be that other current disease-modifying therapies might have similar effects, although they haven't been specifically tested in progressive populations. Now, are there other options that we can use to mitigate progressive MS? So it turns out that smoking, tobacco smoking, is associated with increased risk of worsening disability in people with MS. Furthermore, there's evidence that smokers who discontinue smoking can modify that risk over approximately 4 to 5 years. So if you have progressive MS and you're smoking, or even if you don't have progressive MS and you're smoking, this should be an additional indication to stop smoking. We know that people who have vascular risk factors have not only increased risk of disability, but they also have increased risk of mortality compared to people without MS who have the same vascular risk factors. So hypertension, diabetes, obesity, hyperlipidemia, what's called metabolic syndrome, all have been shown to be associated with increased risk of disability in people with MS, and these are potentially modifiable. We heard about exercise a little bit earlier. It improves aerobic efficiency. It prevents further weakness due to deconditioning. It improves fatigue, mood, and quality of life, and it also addresses some of these vascular risk factors. Furthermore, diets which address vascular risk factors and metabolic efficiency can also help to mitigate progressive MS potentially. We're talking about diets that are low in saturated fat, that are low in sugars, such as fructose, which tend to be of a Mediterranean sort of diet with fresh fruits, vegetables, white meats and fish, and low red meats and the use of saturated oils. Now, there are a number of therapies that are currently under investigation for people with progressive MS, and there is a huge effort, which is primarily sponsored by the National Multiple Sclerosis Society. This is an international effort to find effective treatments for progressive MS. These efforts also include searches for biomarkers. So there are a number of collaborations and registries in which information is being collected on people with MS to try to identify markers which might tell us who's at risk of developing progressive MS. We're part of one of these registries, which is called the North American Registry for Clinical Care and Research in MS, or NARCRMS. If you want to know about clinical trials for progressive MS, you can look at www.clinicaltrials.gov, where all clinical trials are registered. But these are some of the agents that are currently being used. So there are a class of agents called BTK inhibitors. These agents can potentially enter the central nervous system. They work by reducing B lymphocyte inflammation, so they overlap somewhat with the B cell depleters, but they don't actually cause B cell depletion. They also may have potential effects on innate immune cells called microglia, which are activated in MS. And these drugs are currently in late-stage clinical trials being evaluated in both relapsing and progressive forms of MS. In the UK, there is a trial going on with high-dose simvastatin, which is a lipid-lowering drug, which also may have anti-inflammatory properties. And a prior study showed that this reduced the risk of brain volume loss. Another study going on at several centers in the Western US uses alpha lipoic acid, which in a small study also showed reduced brain volume loss. Clemastine is an antihistamine, which is highly sedating and so not much used anymore, but which was found to have some effect in laboratory studies to facilitate remyelination, and was also shown to benefit the speed of conduction in people with chronic optic neuropathy. So this drug is being explored in people with progressive MS as a possible repair agent. Similarly, an agent called nanocrystalline gold has been shown to induce remyelination in animal models by stimulating oligodendrocytes, the cells that make myelin. And this is being evaluated in people with MS who have chronic optic nerve damage. ATA188 is a specific T lymphocyte therapy in which lymphocytes which are treated to target Epstein-Barr virus are given to people with progressive MS. In a very small initial study, there was some improvement in function in people with progressive MS, and this is now being treated in a larger study. Additional studies include N-acetylcysteine, which is a potentially neuroprotective agent, which is initially being explored in progressive MS, monthly glatiramer acetate, and a drug called IMU-838, which is a pyrimidine synthesis inhibitor. It is similar to teriflunomide or Aubagio, which is also being tested in progressive MS, and after showing some effect on progressive brain volume loss in people with progressive MS. So I'm going to stop there, and I think we'll move on to your questions. So if I can have everybody back. And we have quite a few questions. Some of them will overlap, so I'll try to combine questions on similar topics. So I have a question here about the stopping of disease-modifying therapies. So I've heard from a number of people that some neurologists stop disease-modifying therapies once the patient reaches the age of 60. Can you explain why that might be? All right, so how about Roman? Do you want to take that one?
Yes. So there are two things that we have to know about the immune responses in multiple sclerosis. So the very first one is that it's a disease of young adults, and the reason behind is that the immune system is very active at this age. As we get older, the immune system gets old as well, and kind of loses some of its regulatory but also effector mechanisms. And the overall impression is that probably less is needed to maintain disease remission. And probably after age 60 or 65, patients might need even less or no medication. Now, there are no control studies pointing when exactly the point of treatment discontinuation should be. But if this is to happen, it should be discussed with the neurologist, of course. I personally prefer patients to have MRIs periodically after the discontinuation of the treatment. And medications that are taken intermittently, I think that it have no side effects. And if there is a reason to believe that the disease will reactivate itself, because we know that there is this late onset MS, I would actually prefer to keep those patients on therapy.
All right, thank you. I have a question that asks if lesions on the brain from MS will cause Alzheimer's disease. Dr. Grebensiakova, would you like to take that one?
Yes, of course. While accumulating multiple lesions in the brain can certainly do a lot of damage, and that's why we work so hard to control the disease early on, so we can prevent many of these lesions from forming and prevent this damage. The lesions that accumulate, if you have a lot of them and your disease is very poorly controlled, or maybe it's diagnosed really late, this can contribute to cognitive changes that sometimes we can even see early in people with multiple sclerosis. And of course, in those patients who have very long-standing or very poorly controlled multiple sclerosis, or perhaps people who had a very aggressive onset of multiple sclerosis with 30, 40 lesions from the beginning, some patients may develop cognitive changes over time that are similar to major cognitive disorder, or what we also called dementia, but this is very different from Alzheimer's. So Alzheimer's dementia has many genetic factors and is a very different disease and a different process. So having multiple sclerosis does not increase your risk of Alzheimer's dementia or having multiple sclerosis lesions. But if I may understand your question from an angle of an MS neurologist, certainly having a lot of lesions from multiple sclerosis that are, and developing more and more, if, for example, the person is not taking MS drugs, or MS drugs are not working, or they haven't been treated, that can increase the risk of developing neurocognitive disorder or developing dementia.
Thanks, Elena. I have a question now regarding the effect of highly processed food on the onset of multiple sclerosis. Dr. Sleewood, would you like to take that one?
Highly processed food?
Yes, can highly processed food have an impact on MS onset?
Actually, I would defer that to you. You probably are in a better position to answer that.
All right. So to our knowledge at this point, there is no evidence that a particular type of diet can cause MS. On the other hand, there is evidence that diet may affect the course of people who have MS. So with respect to the onset of MS, no, there's no evidence that eating a highly processed diet causes MS, but there is reasonable evidence now that it can impact the severity of the course of MS. All right. I have a question about vitamin D. It's said that vitamin D reduces the risk of having MS. However, in the 2022 ECTRIMS Congress, it was presented that taking high doses of vitamin D did not reduce MS activity. So what is the role of vitamin D in MS? Dr. Perez-Giraldo, would you like to take that one?
Sure, absolutely. So we know that having low vitamin D is a risk factor for developing MS. And we know that vitamin D has a lot of, has effects in immunomodulation. Like having a higher vitamin D has effects on lymphocytes and all these cells that are related with MS. So we definitely know for a fact that if you have a higher level of vitamin D, your risk of developing MS is lower. However, we have not been able to prove that once you have MS and you're on vitamin D, that vitamin D itself is going to change the course of the disease. So it is true, like we know that your vitamin D has a role in preventing MS, but once you have MS, we don't have evidence to say that definitely that is going to change the course of the disease. However, personally myself, I feel like taking vitamin D is something that is benign, it's a vitamin. We know that it has effects on the immune system. I still recommend to my patients that have MS to keep a higher level of vitamin D based on that. But it is true that in trials, it has failed to demonstrate that it has an effect on the disease once it has happened already.
Thank you. I have another comment here, somebody asking for a copy of the presentation as well as the names of the presenters. I'll answer that. The presentation is being recorded. The slide that we showed at the beginning and we'll show at the end indicates how you can get access to the recording if you want to look at it again. Also, that will contain all of our names, and you can contact us through the Northwestern Medicine site if you wish to contact us regarding questions you might have about any of our presentations. All right. Next, I have a question for Suzanne. The questioner says that they used the National MS Society website to locate a doctor in their area, and this particular individual is in the Houston area. They said that the next available appointment for them was 4 to 6 months, and they wanted to know whether there was any way that I gather that the society could help them get an earlier appointment.
Thanks, Dr. Cohen. So the society, has a partnership with MS centers and centers of comprehensive care. So it sounds like you've been able to access our Find Doctors and Resources resource. I mean, I think part of the challenges, and maybe the Northwestern MS Center can speak to this too, is a shortage of neurologists in general. That makes it challenging to get an appointment, although it's so important to connect with a neurologist if you potentially have MS or have symptoms. And what we at the society are doing is we provide funding for MS fellowships to help encourage neurologists to specialize in MS. And we are also offering a medical student mentorship program. And Northwestern is actually a site where a medical student can spend a month with a neurologist, encouraging them to consider going into multiple sclerosis. Maybe you could all speak to it too, but I think the challenge might be that sometimes a shortage of neurologists and just really challenging to get an appointment. So
I'll just make a comment for those in the audience that are in the Chicago area. If in the usual scheduling procedures, people have trouble getting an appointment who have multiple sclerosis, they can contact us through the MS through the Northwestern Medicine MS website, and we will see them. We can see anybody within a few weeks if need be who has multiple sclerosis. All right. This was another one for Suzanne, something about an event in the North Shore, a support group. And, I'm sorry, this is asking about a support group downtown for those with MS. So I can address this. There is a support group at the Shirley Ryan Ability Lab for people with MS. And actually, Jim, I should probably let you provide the contact information for that.
Yeah, the contact information is Roberta Winter is still the person that's in charge of the MS support group here. It was very active. It has gone virtual now because of COVID. It is held on a monthly basis. And by reaching out to Roberta Winter, she will send you all the information you need to log in and to participate. They have monthly meetings, there are support groups, they have presentations on information valuable for everybody with MS. So be happy to provide that information to anybody who asks.
Thanks, Jim.
Yeah.
I have a question now for Dr. Graham. What is the difference between stopping MS before getting pregnant and not stopping MS medication during IVF? Would the egg not be affected as well?
Sure, I can take this. I think part of that question is whether or not being on MS medications, particularly during IVF, could affect the eggs even during harvesting. So actually, unless the medication is one that affects DNA, such as cladribine, it would not affect the egg. So actually, some of our medications, if you're just undergoing something like egg retrieval, you could remain on Gilenya or Tysabri throughout the entire egg retrieval process. It's really not until the embryo is developing that the medications actually have an effect. But what we really want to make sure is that patients are on a therapeutic disease-modifying therapy when they're undergoing hormonal stimulation, and that's to protect them against MS relapse. So I think that's kind of a two-part question, whether or not the treatments affect the egg itself and whether or not the MS is going to relapse with the IVF.
Okay, thank you. This one I think is for Dr. Balabanoff. When should a patient consider more elaborate therapies such as stem cell therapy versus relying on treatments such as disease-modifying therapies?
This is a kind of very broad question, and I will give my perspective. Those aspects of the question are specified by the recommendation of the National Multiple Sclerosis Society, but my personal impression and experience has been that patients should be treated with hematopoietic stem cell transplant relatively early in their disease. So they still have to be in a relapsing remitting phase. They should have tried some effective disease-modifying therapies. What we have currently as disease-modifying therapies, it's very close in terms of efficacy and prevention of disease progression to what transplant is. The difference is that the transplant is a single treatment that does not require future retreatment. So I would say after 1 or 2 medication failures. And again, all this should be done within the time frame of 10 years after the diagnosis and at age earlier than 50. In terms of what the disability level should be sometimes measured with the EDSS, I would say between 3 and 4 is the maximum disability level that patients should have to enter that treatment.
Thank you. So we've had several questions here again about stopping disease-modifying therapies. Let me just try to combine these. The data that's available from observational studies largely suggests that when people stop disease-modifying therapies after their mid-50s, they are unlikely to have recurrent attacks, since we know that attacks decrease substantially after people reach their late 50s and 60s. But these are groups of people. And so therefore, it's still possible for people to have attacks after that time. It's less clear about whether this has any impact on progressive disease. So people who have already developed progressive disease, it's not clear whether stopping their disease-modifying therapy has any impact on the likelihood of their worsening, their progressive disease worsening subsequently. There is a clinical trial which tried to address this, which recruited people who were 55 years of age or older and who were stable for at least 5 years, both clinically and by MRI, to see whether or not if they stopped therapy or if they continued therapy, there would be any difference in new disease activity as measured either by clinical changes or relapses or by MRI. The study only lasted about 2 years and unfortunately was inconclusive. They did not show a difference between the two strategies. Part of that might have been the length of the study, which was limited by funding. However, at this point, I think this is still an open question and probably one that's best discussed with your physician and your own individual situation in a shared decision-making process. All right. Are disease-modifying therapies proving to eradicate disease progression or just delay it? Let's see. Dr. Graham, do you want to take that one?
Sure. Typically, we say that they delay disease progression. And as we know, there's no cure for MS, so there's no treatment that 100% eradicates the possibility of disease progression. But when we look at our disease-modifying therapies, we can categorize them between high, moderate, and mild efficacy. And those that are higher efficacy, we know delay disease progression quite a bit more than those with mild efficacy. And more recent studies have shown that early initiation of higher efficacy therapy is really where we can make the most impact in delaying progression.
Thank you. I have a question now about ATA188, which I'll take. This is the transfusion of T lymphocytes, which are sensitized to Epstein-Barr virus. And the questioner wants to know if this will be available soon for people with MS. So this drug is in early clinical trials at the present time. They have not done a phase 3 trial as yet, although they are planning for one. These phase 3 trials generally take 2 to 3 years to complete. And so until those kinds of data are available and of sufficient impact that the FDA feels the therapy is safe and effective, it would not be widely available. So I certainly, if you have progressive MS and you are interested in this trial, look for its availability in your area and consider going into the trial. The trial will almost certainly be controlled in the sense that there will likely be either a placebo or potentially an alternate therapeutic arm, and you won't know whether you're enrolled in the ATA188 arm or the alternative arm, but that's the only way that these studies can be done to show whether or not drugs are safe and effective. Okay, the next question has to do with a man who has recently been diagnosed with multiple sclerosis and is concerned about the risks to his infant son of developing multiple sclerosis. And he also wants to know if there's anything that he can do proactively in order to protect his son against future risk of multiple sclerosis. So Dr. Grebensiakova, would you like to take that one?
Yes, of course. Thank you so much for this very important question. So what we know is that multiple sclerosis is not, strictly speaking, a genetic disease. It's a multifactorial disease in which, of course, there are certain genetic predilections. But in strict terms, if a mother has or a parent has multiple sclerosis, the risk to a child is about 3 to 4%, 3.5% to 4%. So it's a small risk. And there are important things that you can do to minimize that risk. I think that we know that there are modifiable risk factors in development of multiple sclerosis. So that's vitamin D deficiency. So people with lifelong or frequent vitamin D deficiency at a slightly higher risk. So you want to make sure that your child throughout his life or her life has adequate vitamin D by discussing it with their pediatrician and finding the appropriate dose. We also know that obesity or being overweight is also one of the risk factors. So you want to make sure that the child, as they become a teenager and an adult, are always encouraged to maintain a healthy body weight. We also know that smoking is one of those risk factors. So you, as your child is growing up, you want to make sure that as they become a teenager and a young adult, that they stay away from smoking. So the risk is small. And there are additional things that you can do to reduce those risks.
All right, and there was one other part to this question that I neglected to read. The caller has heard of people getting genome mapping to unlock potential risk. Can you comment on that?
Currently, I am not aware of any specific genome mapping that is clinically approved for that risk to specify. If any of my colleagues are aware of that, they're also welcome to comment.
Yeah, so there are commercial groups which sell genome mapping tests that claim to be able to predict the risk of MS. These have not been validated by the FDA. And so consequently, their reliability is uncertain. Okay, I have a question about long-term studies on long-term effects of the use of dimethyl fumarate. Let's see, Dr. Balabanoff, do you want to take that one?
There are a few. The overall conclusion is that the medication will remain in the category what will be in the mild to moderate efficacy, and it's relatively safe, though there are some cases of opportunistic infections, including PML. There is one point about medications from that category is that seemingly the aging immune system tends to become hypersensitive. And what we've noticed, and it's published, and noticed in our clinical practices, that patients above age of 50 or 55, they tend to develop lymphopenia on the otherwise same dose that they have been 10 years ago. If I were to mention it, probably this is the single most important problem with this medication category.
All right, and Roman, the next one is for you as well. The caller would like to know about stem cell transplantation in people with primary progressive MS.
It's a very important question. Our experience that was published actually with primary progressive and progressive disease in general was published earlier this year. So patients tend not to respond to transplant for two particular reasons. One is that those patients tend to have a lower level of inflammation, and so the primary targets of the transplant in a way are absent. The second part is that the inflammation, if present in primary or secondary progressive, tend to be of different nature that might be sort of aggravated by the transplant itself. And then medications, the way they're dosed, I have to say, they're dosed in a way not to be cytotoxic and neurotoxic, but later in life, with those progressive forms of MS, the medications might become more toxic. And so what we've noticed is not only that there is no improvement, but actually some patients with disability above 6 and 6.5, they actually get worse with the transplant.
Next questioner says they've been approached for a study and want to know if they should join. This is something you should discuss with your doctor regarding your specific situation and the nature of the study and how it would apply to you. The next one is a question about a person's ethnic background in order to determine the best treatment, and notes specifically that not everyone looks like the ethnic racial group that they are actually in. And they also had the same question regarding age of immigration for those people who came to the US at some time later in their life. So Dr. Perez-Giraldo, do you want to take that one?
Of course, it's a great question, and the answer is we don't have significant information, significant data that can guide us on what medication to use based on your specific ethnicity or race. So and that's why we just need more inclusion, like a bigger participation of patients that belong to minority groups, in able to be able to determine that. Even the information that we have now that maybe interference, maybe patients that are African Americans or African descent, they don't respond as well as compared to other ethnicities. That's all in retrospective studies, meaning we really don't have enough information to definitely make a recommendation on that. So the answer will be that up to this point, we don't know. And regarding the immigration status, like how old you were, I also don't think that that is something that will take into account when we're choosing a medication. We just don't have enough information to do that.
Thank you. Dr. Graham, with higher risk fertility treatments such as cryopreservation and embryo transfer, do you advise patients against these or just provide careful treatment plans?
It's a great question. So our goal is to support safe fertility treatments for our patients. So I do not have a blanket statement to advise against them. I do think that they are safe if you are on a therapeutic treatment at the time that you are receiving hormones. So it's very important. It's all about the timing and working with your MS doctor. But by no means do we recommend that MS patients need avoid all fertility treatments at this point.
All right. The next questioner wants to know, if you're on an older form of treatment, how do you know if and when you should try a newer treatment? So maybe I'll take that one. So there are many people who were started on therapies that were available decades ago and are doing well on those therapies. For those people, there is no need to change to a different therapy if that therapy is effective and if the disease is being monitored through both clinical follow-up as well as imaging follow-up. For those people who show breakthrough disease, in other words, new activity, either clinically or by MRI, that may be indicate a need to consider an alternative form of therapy. And the next one has to do with why the cost of Tysabri has more than doubled across the Chicagoland area in the last year. So I can take this one also. The distribution of medications is extremely complex in the United States. It has to do with pricing, which is to some degree inaccurate and non-transparent, because list prices, which are known as wholesale acquisition costs, are figures that are used to negotiate discounts by the people who actually provide and pay for the drugs. And unfortunately, many of these discounts may not necessarily be directly used to help reduce the cost to patients' out-of-pocket costs. The MS Society has been very, very much engaged in this. You may be aware that the Medicare laws are going to change with respect to this to limit the out-of-pocket costs for those people who are covered by Medicare. For those people who are on commercial insurance plans, the manufacturers of many of these agents, including Tysabri, provide benefits to patients to offset the out-of-pocket costs. So you should discuss either with your prescriber, or you should discuss with representatives from the National MS Society through the Navigator access regarding which of these sorts of situations might apply to you. Okay. Let's see, this is requesting copies of the presentations. Again, they will be available through the website. Here's a question: should someone with mild symptoms be using a more effective disease-modifying therapy early on, Or is it better to wait until mobility and cognitive function deteriorates? And this particular individual is currently on glatiramer acetate. So in general, we believe for somebody with mild symptoms, we don't yet know whether or not using a more effective therapy balanced by whatever increased risks might be associated with that would be better for that person compared to using a therapy which may have less side effects, but may also be less potent. However, we don't want to wait until somebody develops disability to change. So at this point, there is a school of thought that we try to start everybody with more potent therapies, or at least moderately potent therapies today, who are first presenting with their symptoms, even though we know that perhaps 20% of those people ultimately may not need that more effective therapy. There is another school of thought which currently believes that in people with only sensory symptoms, for example, numbness and tingling, but no weakness or clumsiness or cognitive impairment, might do well on a milder therapy, and that's currently being tested in clinical trials. So to some degree, this represents also shared decision-making, and you'll see different positions on this with different individuals. This is different than someone who's been on a mild therapy for decades and is doing well. That person has already to some degree declared their natural history. Okay. This is an individual who is in their 80s and who was diagnosed at age 28 and is now starting to experience some weakness in their legs. They're vigorous and they'd like to know if there's anything that they can do or take that might help at this point. Let me see, Dr. Grebensiakova, do you want to try that one?
Yes, of course. So thank you so much for this question. So if you're in your 80s, the chances are is that whatever form of multiple sclerosis you have had, it is in its what we call quiescent stage, meaning that you are unlikely to have new attacks, new relapses, or form new lesions at this point. However, as we get older, there's a couple of factors that are at interplay. One is as we become older, particularly if we already have some pre-existent weakness in our legs or neurological issues, we may become more prone to deconditioning. We may become prone to losing muscle mass at a faster rate in our 70s and 80s. So that's number one. Number two, there are also lifestyle factors that can contribute to somebody having more of an issue with progression or issues with worsening of weakness in the legs. So those are lifestyle modifiable risk factors. So somebody who has, for example, severe poorly controlled diabetes or poorly controlled high blood pressure or cholesterol, those things can contribute to what we name secondary progression. And we know that people who have had MS for a very long time, particularly, right, for 30, 40 years, they're more prone to experience what we call secondary progression. But secondary progression is only in part multiple sclerosis itself, and it's associated with atrophy in the spinal cord and brain. But it's also other things. It's things like deconditioning. It's things like getting older and losing muscle mass. It's things like those modifiable risk factors that I mentioned, and also most importantly, you know, there are other causes of weakness in the legs. Like, for example, rarely statins that we take for cholesterol can cause muscle weakness. So never stop your statins, but discuss with a physician if this could be a contributing factor. Sometimes, you know, diabetes or vitamin B12 deficiency or even thyroid issues, you know, can cause worsening muscle weakness. And so it's really important to, you know, get evaluated for the causes of these worsening weakness that can be multifactorial, and to resolve them through modification of lifestyle risk factors and also physical therapy.
Thank you. This next questioner asks, for people with no lesions over several years, what are the benefits and risks of starting a disease-modifying therapy versus a watch and wait approach? So this depends on individual situations, including your age, when you were first diagnosed with MS, whether you actually had symptoms or whether you have what we referred to as radiologically isolated syndrome, which is having MRI lesions initially, but no symptoms. And this is something that you should discuss in detail with your MS physician. People are asking about familiarity with Copatine, K-O-P-A. Does anybody know anything about that? I don't. Okay. This is a question regarding stem cell therapy, and the questioner wants to know if it's an option for early diagnosis as opposed to after other treatments have failed. Dr. Balabana?
Well, it's certainly an option if there is a willing patient and a willing center, but I would say, the risk that are associated with the actual transplant should be factored in. So the reason is not a first-line therapy because of those upfront risks that patients may avoid by just kind of trying a treatment. FDA-approved treatment, like a disease-modifying therapy. Now, perhaps in time, the hematopoietic stem cell transplant as a treatment step in the chemotherapies can be adjusted in a way to be very safe, of course, but at the moment, the risk probably is greater than what the effective disease-modifying therapy is.
All right, two other questions. Can somebody over 55 years of age get a stem cell transplant, and is the procedure covered by insurance?
It depends. So if above 55 is certainly possible, but those patients should have very low evidence, I would say, of fixed disability. The problem is that, again, the nervous system after a certain age becomes more sensitive to chemotherapy. So if it's primary relapsing remitting, or if it's a poorly controlled, very active disease, so they would develop a critical lesion, let's say large spinal cord lesion or midbrain lesion, I would say yes. So at the moment, the transplant is not covered by the insurance. I said there is an option to compassionate treatment, and depending how the insurance is set, but by and large, the patients have to pay out of pocket for that treatment or participate in the clinical trial.
Thank you. So I have a couple of questions here. How can remyelination occur? It occurs when cells that make myelin, that are able to make myelin, called oligodendrocytes and oligodendrocyte precursor cells, can migrate to the location of an area of inflammation, and under the right circumstances with the right elements in terms of growth factors and similar molecules attached to surviving nerve fibers and remyelinate them. The second question, which is related to this, is axonal damage present in both relapsing, remitting, and secondary progressive MS, and the answer is yes. Unfortunately, we are approaching the end of our allotted time, and you've been wonderful in terms of giving us lots of excellent questions. I apologize that we haven't had sufficient time to get through all of them. But certainly we will show you again the slide where you can get access to the presentations, where you can get access to those of us who were presenting to you, and as well as to the various resources that are available from the National Multiple Sclerosis Society. So once again, I'd like to thank the MS Society and Shirley Ryan Ability Lab and Northwestern Medicine for allowing us to present this program once again next year. And most of all, I'd like to thank all of you for your attendance and active participation. And I hope you all have a good rest of the day. Thank you.
Thank you, everyone. Bye.
Bye, thank you.
So long.
Thank you.